Hello! Welcome back to Cozy Couch Contingencies, the podcast where your two favorite BCBAs get comfy, get real, and get into the messy, meaningful parts of the best work we do.
We're so glad you're here. Whether you're on a lunch break, driving to a home visit, or hiding in your car between clients, no judgment.
We've been there. I'm Krista.
And I'm Melissa. And today we're diving into a new topic that comes up a lot. Whether you're a new BCBA or a seasoned one, and that's stereotypy.
Yep, the scripting, the hand flapping, the spinning, the humming. Stereotypy shows up in many ways. And if you're anything like us, when we first started, you might be wondering, what do I do about it? Should I intervene? Is it harmful? Or is it just different?
Exactly. And those are all really great questions. Stereotypy is one of those things that can make people feel a little uneasy, especially when you're still trying to figure out how to balance ethics, clinical decision-making, and client-centered care.
Yes, so let's get into
The basics.
What is stereotypy? Well, we have a book that we love dearly.
The Bible of ABA.
The Bible of ABA. Cooper. And unfortunately, there's not much about stereotypy in Cooper, if anything. We looked in the index, looked in the glossary, couldn't find anything. It's been a while since I've had to actually read Cooper front to back, but I don't really remember much about stereotypy in here, which was one of the reasons why we kind of picked this topic, because it is something that we know about. A lot of our kids, even we, engage in stereotypy. Mm-hmm. So we kind of wanted to touch base on it since it isn't in the Bible. And it's not something that a lot of people know how to intervene with. Mm-hmm. And I think we both have had very interesting experiences learning how to maintain our clients' dignity. Mm-hmm. And also kind of understand how it affects the stakeholders. Mm-hmm. And what we think may not be what they think. And that's okay. And that's what our goal is, right? We want to make sure that we're doing what's best for the clients and their families and making sure that they know that we're there for them as much as they really want us to be.
Mm-hmm. It's true. And that's key. Just because something is automatically reinforced doesn't mean it's bad. It might be calming, regulating, enjoyable even. I mean, I'm a huge fidgety person. These fidgets are my life. You know, my husband 3D prints them just because I'm a fidgety person. And these sorts of repetitive motions, they help calm me, they relax me. A lot of kids are the same way. Our client-centered care, that's something we think about. So it might be calming, like I said, regulating, enjoyable, or just part of who someone is.
And I think early in our careers, especially, I've been in ABA for 7 years. You've been in ABA for,
forever. I don't know.
A long time.
And
it wasn't something that was talked about. It was something that you reduced. You put on extinction. And for those of you that don't know what the term extinction is, we're going to link some definitions and kind of talk about some of the terms that we use in our day-to-day when we are working or when we're trying to figure out how to write it into a behavior plan or whatever it may be. So if you hear terms you're not familiar with, we're going to do our best to kind of link definitions and explain them at some point. Mm-hmm. So we were taught to put stereotypy on extinction a while ago. Yeah. And that's something that we want to make sure that we're really pushing is that we're no longer doing that.
Yeah, there's so much research out there. I've just been reading up on it. It's been interesting to see the change from the 80s, 90s, and then it's all no, and even early 2000s, and now more recently we're seeing some of those, hey, wait a minute, this is something we want to check out more. So looking back, I wish that somebody said pause and ask why it's happening, and then ask if intervention is really necessary, because nowadays that's more what we're looking at. We're looking at assent, we're looking at client-centered, sort of behaviors, and we want to make sure that it's something they need.
So, 100%, couldn't agree more.
Yeah.
So as we kind of jump into this podcast today, we are going to talk more about what is stereotypy, what is the definition of it, why we are no longer putting it on extinction. I think we touched about that a lot already. But just kind of when do you intervene and how we can kind of better support you and also call it our own stereotypy. So hope you enjoy.
Thanks, guys. So welcome back, guys. We're here with Krista. We're going to talk a little bit more about the stereotypy situation and a little bit more information on that. So, Krista, what is stereotypy?
So that's a great question. We never had it truly defined for us, to be honest with you. So when you Google the definition of stereotypy, what comes up is that it's a repetitive behavior that has no clear social function. And it doesn't mean it's not meaningful. It doesn't mean that it's not there for a reason. It might serve a purpose of automatic reinforcement, as we all know. Automatic reinforcement is how we were trained to say it, but now they kind of been moving in the SEAT acronym of sensory. So it might serve that sensory function for the individual.
Yeah. So then moving on, sort of taking a deeper look, when would you intervene in this whole situation? Do we automatically jump into intervention?
I don't think so. I think we got to talk about that because sometimes interventions make sense. Obviously, we love a good intervention, but when do we intervene is the real question. If it's not interfering and it's not bothering them, it's not bothering their families, there's not saying that it's something that they need to decrease because they can't leave the house or the child can't get their shoes on or whatever it may be, academically they're succeeding.
Yeah.
Why do we need to intervene? If they know how to engage in stereotypy appropriately, why do we want to decrease that?
True.
If that's how they regulate, that's how they regulate. I sit here and I, rub my feet together and engage in my own little stereotypy.
Oh, I have that going on here too. I get it.
So it's something that isn't always, it can be viewed as a bad thing for people that don't understand it. But for us, it's something that we can teach you how to work around it, and we can teach you how to still be functional and have those meaningful relationships. But when we do need to intervene, is when it gets dangerous.
Yeah, right. I definitely have run into a few of those things. For example, I actually had a learner who would engage in some severe head hitting, but it wasn't maintained by any sort of other function. It was strictly automatic or sensory seeking. We would, do all the things to try to eliminate. We've done a lot of different, we did a full FA actually on this client back in the day, and strictly all for the sensory. So we did have to put an intervention in place. However, it was very complex, and it was definitely something that was out of our realm and scope a little bit. So we definitely had to call in some more professionals, but it was an interesting case.
Yeah, that's when you definitely need to step in and intervene.
Yeah.
And I think the hard part when it comes to those behaviors that are dangerous and so scary at times, it's like, what sensory input do they need? How do you match that? How do you get the functionally equivalent behavior? Like, what do you do to get that to stop? Because it may end up coming back up. You place something on extinction, we all know about spontaneous recovery, that it can come back at any point. So how do we prevent that from happening? So it's definitely something that you have to be so careful with.
So true. Do you have any examples of kiddos with yours? I'm sure you do.
I have a few. I worked in a clinic as an RBT when I first started in my career, and I think you don't see it as much by the time they get to elementary school, middle school. They kind of figure it out or have had interventions previously that have helped decrease the behaviors. But I think one of my favorite ones is one of my students would sing commercials. So
I love that.
he would be supposed to be doing DTT, and he's sitting there singing you a commercial. So that was pretty fun. And then I actually had a student that would grind his teeth. And he would do it in a very stereotypical way. He would move his jaw the same way every single time.
Ow.
And then the same student actually I had to place his behaviors on extinction because I became a script. And he
You're
would
a likable
always
gal.
say, "Hi, Krista," and would say it in that exact way and emphasize the Y in my name. So it was really funny, and it became very distracting. There was a point that I couldn't even walk by a classroom he was in there because he would then get off track. And his script to me would start the rest of the scripts. So it was interesting, but it was fun. And Definitely, I felt very special that I became a script, I'm not going to lie.
Yeah, it does give you a little bit of a confidence boost, I'd say.
It does.
Sweet.
It does.
But also, it's one of those things that you have to kind of think about the real questions when you're getting into it. Is it harmful? Not really, not this particular one.
No.
However, who knows down the way it could evolve. Is it interfering with access to learning? Potentially. Safety
definitely was sometimes
Yeah.
on that case.
Safety or that meaningful relationships, those building a relationship with you, it kind of was. He was getting your attention. And does a learner want to change it? Or are we reacting based on those neurotypical norms?
You can say that again. Because too often we jump in because something looks different. If it's not causing harm, why are we jumping in?
Yeah, I mean, we have to kind of think about it. Is this really going to, make a big difference in the client's life? Or is it something that they can continue to engage in and still go about their day?
100%. We just have to make sure we're doing what's best for them.
Mm-hmm. Agreed. So let's talk about language for a second. Words like inappropriate or non-functional get thrown around a real lot with this topic. But we have to ask according to who or whom. Is it us that are saying that, or is it something else that we're thinking of?
Yeah, when someone calls someone stimming non-functional, surprise, there's a function. There's a reason that they are doing that. We just need to figure out why they are doing that and prioritize their way of stimming is their way of regulating themselves. Mm-hmm. And at the end of the day, I think something as a field ABA really has moved away from is compliance over, we don't need them to comply all the time. Mm-hmm. They can do what they want to do sometimes. They are humans. Imagine being told every single day that you couldn't engage in reading a book or scrolling on your phone or talking to your family. Like, these are simple things that you just do day to day. And stimming is something they do day to day. They may do it hour to hour sometimes. So why are we going to tell them no?
Right. So when we write those goals or behavior plans, we always want to try to reframe. Instead of reducing flapping, maybe that goal is going to expand ability to participate in a group activity for up to 10 minutes. There's a difference there. So the difference is more so, hey, we don't mind you engaging in this behavior, but we want to make sure you're able to do this instead or still continue to do this behavior.
Mm-hmm. I love that. It is definitely more support focused, which is something we need to make sure we're really drilling into people that we are there to support them. We can teach them when the behavior can be on. We can teach them when the behavior needs to be off, but we're not placing it on extinction anymore and making it go away. Yeah. Unless it's dangerous, then that's
we do need to intervene.
Topic.
Yeah. Stay tuned for that one.
Caveat. Don't forget about the dangerous part.
Yes, of course.
So I think something we are going to dive into shortly is kind of what do you do? What are some practical things you can do? What are some day-to-day things that you can do? So just hang tight and we'll be right back.
Sounds good. So welcome back, guys. Let's talk about when you do need to do an intervention. What are some compassionate, ethical strategies you can use?
I think my number one advice would be to start collecting ABC data.
100%.
You really want to make sure that if you are looking at stereotypy, that it truly is automatic reinforcement or sensory, as some people call it. So you want to make sure you're kind of checking off those other boxes. There's an acronym that we use. It's TEAMS. So T, tangible, accessing a tangible item. E, escape or avoidance. They're kind of lumped together. A, attention. M is medical, which is something we're actually kind of going to take a little dive into next week. We're going to talk about how some things will come from other things. I don't want to give too much away.
Just a little teaser.
But
it's coming.
How we have to truly make sure that we are standing by our ethics and we are not getting involved if medical has not been ruled out. And that is something that we are very firm on in ABA, that if there is a medical component to anything, we need that ruled out. We need a doctor's note. We need to know that everything's okay before we start any type of intervention. And then the S is for sensory or automatic reinforcement. Alyssa and I started in ABA a little while ago, so we use the term automatic reinforcement more than we use the term sensory.
Mm-hmm. I'm just starting to now get comfortable using that term.
Yeah, it's still weird for me.
Yep, a little bit weird.
It is. At work, sometimes I'll use the term sensory, and I'm like, ooh, I still don't know how I feel about this. It's automatic reinforcement. I feel like it doesn't give the same vibe for some reason. I don't know.
I don't either. It's just different.
Yeah. So that's where I would kind of start, and just see if you can rule those other functions out. For those of you that don't know, ABA has 4 functions of behavior. Life has 4 functions of behavior, just so you know. Everything is maintained by something. You just kind of have to figure out what it's being maintained by. So if you're finding that your child is kind of doing the wrong thing and you're giving them attention all the time, but you're never pointing out the good stuff, they're getting your attention because they're doing the bad things or they're doing the things you don't want them to do. Mm-hmm. So really start pointing out that good stuff and see if it works for you.
Yeah. It's life hack.
Right?
Then the next step we would go into after, tackling that piece of it, the ABC data and those sorts of things, we'd ask, can we teach a replacement behavior for this? Can we embed access to sensory input into the day rather than taking it completely away, giving them a time frame of when they can use it? Can we increase engagement in meaningful preferred activities, other things that they might love to do, and just kind of replacing them in that direction?
Yes, and please, 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 please don't punish stimming.
Oh, God, no.
We do not want to put stimming on any punishment procedure. We don't want that happening. If it's harmful, that's a different story. You will have to figure out what you can do, but still punishing it is never going to make it go away. So we want to make sure that as a field, we're kind of moving towards supporting regulation, but also knowing that that's their identity. That's who they are. Mm-hmm. And we don't want to change that. We want to help that. And we want to make it functional enough that they're able to do daily life tasks and have conversations, mm-hmm. or get maintain meaningful relationships with their peers, but we don't ever want to change who they are.
No. And one of my favorite strategies, besides all these other pieces that we're doing, is incorporating movement or sensory play into sessions so that they don't get to miss out on those opportunities and those, kind of tying into what they need. Proactively meeting those needs instead of reacting when stereotypy happens or spikes. It's a really good way to take and swap it out.
Proactive, not reactive. One of my favorite things to train people on. Antecedent strategies work. They're great.
Oh, so great.
They're lovely.
So great.
So always be proactive, not reactive. I think any behavior support plan mm-hmm. you will get from me, if one of my kids accesses OTs for sensory input, mm-hmm. I will write in there that they need movement breaks throughout their day. They need to be scheduled. They need to be predictable. Mm-hmm. They have to be in their day. Otherwise, you're going to see that increase in behaviors.
Oh, yeah.
So just making sure that they're in there. And I think one of my favorite tips to give people is I work with the population of kids that have emotional disabilities. So sometimes they're not as apt to really want to follow through with anything that we say, especially the older they get. Mm-hmm. And one of my favorite tips is to give them a job.
Ooh, yes. I always love that one.
Hey, right? Hey, can you go bring this note down the hallway to so-and-so? Mm-hmm. They're going to bring the note. They're not going to know that you're giving them a movement break, or, I have this library book that's overdue. Can you please go bring it back to the library for me? They have no idea. They just think they're doing you a favor.
It's functional, but it's also giving them a movement break, and, it's a win-win all around.
It works. So really embedding those is definitely important.
100%. Oh, yeah. Ooh, some lessons from the field.
Oh.
You got any?
What have we learned, Alyssa? I feel like we've learned quite a bit. Still more to go, but
always.
We're learning. I feel like every day we learn something new.
Always. So many things.
So, I think story time.
Good stories. I love stories. Thank God we have our cozy blanket.
I know, right?
Yeah.
Story time. Maybe we'll get the fire set up soon. Have cozy fireside chats too.
Love it.
But what's a story that really sticks out to you? I know you've had, this is also something I really want to do at some point with Alyssa, is she's had so much experience, so much. And I think we all have questions for Alyssa because she's worked in clinics, schools, and she's worked remote, so she's really done everything that we can do within reason. except like working overseas, I think is probably the only thing she hasn't done yet.
Don't tell me with a good time.
I know,
Just
right?
kidding.
There
I
was,
like my United States.
there
I'm
was a
happy here.
job one time for like Japan, and I was like, ooh, living on an island in Japan sounds nice right now.
Doesn't sound awful.
So, but I think I would love to have more of your experiences. So, what is like a story that you have? Because I feel like you've had more experience with really, as a BCBA, decreasing stereotypy or functionally teaching it. So, what's a story that you have for us?
Oh, one of my clients was a really big mouther, I'd say, and like always mouthing objects, and that was the way he kind of calmed down. And we kind of were like, okay, yeah, we're in a school situation, which is also a very different setup for this. But I was like, I can't take this away from him, because one, it calmed him. Two, he wasn't hurting anyone. He was still engaging in work. He was still doing all the things. In fact, he was focusing more when he was engaging in his behavior. And he was just so regulated. And I remember when I first started and I saw him doing this behavior, and teachers were like, don't do that, don't do that, don't do that. He went under his desk. He had some serious behaviors when they were telling him no. Fast forward a little bit, gave him a chew, gave him some of these things. Again, it does stigmatize. However, we were able to fade the chew duration. So, as he got better at things and he got more comfortable, he started using the chew less and less actually on his own. But it was something that we knew, okay, we can always decrease it that way if he, is overusing it, or if he is getting, the social kind of pieces that were kind of negatively seen. But it was kind of an interesting kind of solution to situations. Like, he figured it out on his own, which was great.
I love that.
So, I think it was kind of fun to see him change his behavior, and he actually became more comfortable in the classroom. He was raising his hand more. It was amazing. It was actually really cute. It was an amazing story, and I was excited to see it.
Good for him.
Yeah.
I love that.
Yeah. Do you have any good stories on Stims that we've seen?
Honestly, not as a BCBA, so I don't think I could truly say that I've had to intervene. But in my old position, wasn't quite an RBT, wasn't quite a BCBA, it was in the middle. And I had a student that would hit himself in the jaw. And we all thought it was stereotypy. However, it was not stereotypy. He had chronic ear infections. And that was how he would get the pain to go away.
That medical.
So I kind of started picking up on it the more that I was with him. And it was something you could smell the infection, because it would be so bad that it would like be draining out of his ear, and you could just see he was in so much pain. And so every time we saw those symptoms, I would have them take data, and I would say, take the clicker and click every time he hits himself in the jaw. There were days he was over 1,000 times of hitting himself in the jaw. And then we would take the data when he wasn't feeling good, and he would still hit occasionally, but probably in like the 100s range for a 7-hour day. That's really, compared to 1,000, like
very big difference.
Very different.
Yeah.
So we were able to actually bring that data, his parents were able to bring that data to the doctor and say, like, this is how much it's truly affecting him.
Yeah.
And then we were able to rule out, like, obviously we couldn't intervene at that point because it was nothing that we could do either way. Even if it was ruled out medically, when someone's in that much pain, there's not much you can really do at that point. So we were really able to focus on keeping him safe, keeping him, doing activities with him that he was using both hands. So he wasn't able to, stopping him from, we would be able to block him because we could see when he was going up to do it. So there were so many interventions we could put in place to try to maintain his safety while also understanding that that was his way of coping with the pain. So that's where that medical piece too, kind of why we brought it up this episode.
I'm really excited about the next piece of it
Yes.
too. But this is really important why you need to rule out medical.
It's
my first go-to if I can't.
Always.
just to make sure we check that box off, because if you can't rule it out, then you need to make sure you check everything off and make sure that that child is safe.
100%. Because I can't imagine if we put some sort of intervention that, I mean, I don't know what we would have done, but it would have been really heartbreaking to go back and not realize that.
Yeah, you're taking that voice that they're saying there, that's their way of saying that I'm in pain, and you're saying you can't feel pain. You can't tell us that you're in pain, and you're shutting it down. Mm-hmm. So luckily, in that situation, you guys were able to take and at least collect the data to prove there's something going on.
Yes.
Indicate that, our ADA, we can't use it until we know, which is great. That's great. That's a great tool that you guys use, data collection all around.
Yes, data. Not great at graphing it sometimes, but it does help, especially in situations like that.
Oh, for sure.
Yes. So, thank you for joining us. We just kind of wanted to sit here and talk about something that we don't feel is addressed as frequently as it probably should be.
Yeah.
And we wanted to make sure that we were, as we said previously, kind of gearing this towards new BCBAs. Mm-hmm. If you're feeling stuck, if you're feeling like, I don't know what to do when it comes to stereotypy, reach out to us.
Yeah.
We'll post our Gmail again. Gmail?
Yep.
Gmail. Oh, this is really good at social media and technology. Not so much me. So
I'm trying.
She handles it all. She's great. So we'll post our Gmail. If you have questions, if you have a situation and you're really wondering things, call us. We can work it out with you. We could have you as a guest on our show, maybe.
Ooh, I love guests.
Which we are definitely going to do in the near future.
Mm-hmm.
So just always know that, again, like we said before, you're not alone. We know it's normal to not feel like you have the confidence to handle some of these things, but you have the tools in your toolbox. You just need to know how to access them.
Mm-hmm. Yeah. And just remember that also a few other things that I wanted to point out. One, we're going to put some articles at the bottom, too, to kind of check out that have a little bit of this in there. So if you want to take a deeper dive, do it. We recommend it. We've been looking at it. But different doesn't mean wrong. And sensory regulation is a valid need, not a problem to fix.
Mm-hmm. So whether you're rewriting a behavior plan or just thinking about your perspective, know that honoring your client's dignity is always the best way and the most ethical, because we truly live by our ethical code.
Yeah. And we hope today's episode gave you some clarity and maybe a little comfort. You're not alone in figuring this out. We're here. We got you.
So next week, we will be talking about pandas. It is something that neither of us actually have much experience with.
No.
Basically none.
Yep.
I don't
fair
have
to
any.
say.
Yeah, I don't have any experience with. But we kind of wanted to bring this topic to light. And as we said before, medical is something we do not intervene with. And pandas is something a lot of kids with autism actually end up developing.
Mm-hmm.
So we kind of want to jump into that and talk about it a little more, I guess.
Learn out with us.
Learn about it together. Yeah. So we may not know what we're talking about, but we're going to research it and kind of figure out what it is. How do we help it? How can we, like we were talking about earlier, how do we get them to be able to still be functional, but knowing that this is all going on? So we just wanted to touch about it.
So stay tuned, and until then, stay cozy and stay curious.
And cheers to Cozy Couch Contingencies.
Mm-hmm.
What were you drinking tonight?
Coffee.